Good morning, everybody. The topic which being allotted to me is about the escalating the treatment ladder in Meniere's disease. We do all get cases of Meniere's disease at different stages, and this is something which I personally follow in my practice. This shows the pattern in which any patient presenting with the Meniere's, we try to treat at what stage of the disease the person is presenting. Is the reassurance, psychological support, diet, beta-histine, intratympanic injection, tenotomy, and again Mintat, labyrinthectomy, sac surgery, vestibular nerve section. These are all destructive procedures. The medical line of treatment, the very first presentation, it starts with the reassurance to the patient. We have to explain them that this is not a life-threatening condition, this is not related to the brain, because people have got doubt in the mind that whenever they have vertigo, tinnitus, they feel that something is wrong with the brain. So they need a lot of reassurance, lifestyle modifications, diet, low sodium diet, diuretics we do use routinely, lactose, potassium supplement because sometimes there is a depletion, and they are very anxious patients, so they need anxiolytic. There are quiescent stages of Meniere's. We have to take detailed history, go for a clinical examination, do neurotological examination, audiological testing, vestibulometry, and imaging depending on the requirement. Acute episode, the management is entirely different. Most of these acute vestibular patients, acute attack, they are seen by neurologist or whosoever is on duty in the casualty. Again, there is a bed rest, they need a dark room, a steady head, IV fluid. Diazepam is very useful in acute disease. Antiemetics, and you have to watch for nystagmus, blood pressure, take blood sugars, and do neurological examination. Cardiac assessment is also essential. First line of treatment as we go for is treat comorbidities, diet, the caffeine restriction, salt restriction, beta-histine. Even though there is no documentary sort of an evidence that it is useful, but it is supposed to increase the capillary blood flow and help. Diuretics and reassurance. The second line of treatment, when the first line of treatment is not effective, we go for intratympanic, and the first choice of drug which is there for treating Meniere's disease, dexamethasone. And there are a lot of articles about the efficacy and usefulness about the intratympanic injection of beta-histine. There is one video which is not included here. 4 mg per ml, because the dexamethasone which is available at our place, it is not 48 mg per ml, it is 8 mg per ml, and there are many protocols which are followed for giving intratympanic therapy. I follow it 4 mg per ml in 3 sittings. Third line of management, intractable diseases, when there is a vertigo, there is a conservation of hearing is to be needed, we can go for intratympanic gentamicin, and when there is a serviceable hearing is not there, we can try intratympanic gentamicin, and this is very useful in drop attacks or Tumarkin's crisis which we see. Selective vestibular nerve section is very popular treatment, and we have started doing this procedure. Dr. Pradeep, I think, is doing a lot of vestibular neurectomies in our country. Labyrinthectomy with cochlear implant has been in vogue and is still used. As I have already told you, for drop attacks and incapacitating vertigo, line of treatment is the destructive sort of a surgery for the disease. In surgical management also, we can try for endolymphatic sac operation, although it was named to be a sham surgery at one time. But long-term control of vertigo and stabilizing hearing loss, it was important. Shunts from to the subarachnoid space, they have been tried with very less significant difference. Labyrinthectomy and vestibulolectomy, I have already told you about this. This is one particular slide which I borrowed from my friend Dr. Charu Jagtap. This is a research which is now going on about microcatheter and osmotic pumps and constant infusion systems which are being evaluated, different molecules are being evaluated. The most important point I like to highlight is Meniere's disease patients we do get at different stages of the disease presentation, and we do get early patients where there is a hearing is normal. There are patients those who have got non-serviceable hearing. The attacks are variable. The person may not get a classical audiogram which we see, which we have been taught in our career, low frequency audiogram and all. We see audiograms of all types in Meniere's disease. And even though there are a lot of controversies regarding what works better and what works in some patients, it may work. The basic line of treatment which I follow is diuretic, beta-estine in initial stages, anxiolytic. Again, thank Dr. Prasad and team for providing this opportunity. Thank you very much.
Thank you for the elucidating talk, sir.